Welcome to a roundtable discussion on contemporary management of esophageal cancer, focusing particularly on surgical approaches. The current chat will be about post-operative management of patients. We have a number of international expert surgeons joining us here. Please introduce yourselves.
Steve Demeester from Portland, Oregon.
Magnus Nilsson from Karolinksa-Institut, Stockholm, Sweden.
Mark Ferguson from the University of Chicago.
Gail, University of Toronto, Canada.
Jan van Lanschot from the Erasmus University in Rotterdam, the Netherlands.
So let me open this up by asking about ERAS protocols and their role in surgical management of esophageal cancer.
Well, I think it's extremely important. You can make a huge difference in the recovery of the patient by having a standardized pathway and by really pushing mobilization and you know, helping the patient get in command of him or herself as good as possible with a structured program. So we started in 2014. We more or less adopted the program that Don Lowe developed. We didn't go to Seattle, but we brought the team over to Guildford, to Sean Preston. We had, you know, physiotherapists. We even had the department economist, and bought the concept more or less as it was, and it really made a big difference for us. Our ICU readmission rate dropped from 30 to 10%, and it's still at that level. Our length of stay hasn't changed that much, a little bit, but that's because of other factors. But the way the patients handle and tolerate complications, I think that's the main difference. They are so much better off if they have a leak when they're already mobilized and in the ward.
We also use a ERAS protocol, probably very similar, and I think an important component of it is patient expectations. So it starts before this day of surgery. It starts at the pre-operative visits and telling them what to expect, and you are going to get up and out of bed, and you are going to be doing all these things, and having the whole team, so the nursing team knows what's going to happen. Very important.
So it's a big institutional and team commitment.
Absolutely.
But you've referred to early ambulation.
Yeah.
You've referred to patient education.
Yeah.
Of the multiple components of these types of enhanced recovery programs, which of the two elements, for example, do you think are most vital?
I think without patient education, you can't do anything. So, I mean, that's a basis. That managing the expectations of the patient and of the staff, everybody has to say exactly the same thing. But if you look at what really works, I think it's the mobilization, the patient being mobilized on the day of surgery, sitting up for 4 hours, and walking the first day after surgery, and so on. I think that's probably the main mechanism for the change. But without motivating the patient and educating the patient beforehand, you can't achieve that.
I would agree. I think it was the mobilization that makes the difference. But you have
So what's your expectation for mobilization?
They have to be, I would like them to be out of bed the day of surgery. I would have to say that's the thing that we fail on most often. But they're definitely out of bed and walking the day after surgery. Probably not as much as I would like them to be. But
Safe to say that's always the case in my institution. Yeah. But when we started something similar to this, our first patient was a 88-year-old priest. And I met him in the hallway at 8 o'clock that night. He was putting in a 100-kilometer walk out in the hallway. So he had been educated, he was committed, staff was committed. It's easy to get him ambulating right away if you make that the plan.
that is impressive.
Steve, any experience with this?
Well, I think there's no question. I mean, that's why if you look at the discussions on centralization, it's both surgeon and center volume that are important. I think the center volume piece is this whole piece of these recovery paths. So I think it's important, but I also think that, you know, each patient is different, and you can't take every patient and plug them into the same thing, because, you know, a little old frail lady is not going to be as quick and as agile as a young patient. So you gotta be able to adjust a little bit. Mm-hmm. And pain control is very critical.
Yeah, I think the third leg of that, of the three things that are most important at the top, is pain management.
Yeah.
And non-narcotic, ideally.
And what is your preferred pain?
We give pre-operative.
Epidural.
I'm sorry?
Epidural.
Yeah, we try to avoid epidurals in these patients. So what we've been using in a number of patients now is a lidocaine drip in place of an epidural. And that can be done on the floor. You just have to check levels every 12 hours or so, and it's quite safe. There's very few side effects, and it's very effective.
IV drip.
Yeah.
Interesting.
Infusion.
Yeah. We have gone to no epidurals.
Yeah, you're abandoned.
Abandoned.
Even for open surgery, or this is just minimally invasive?
For open surgery, we still sometimes use them, but more and more we're going to blocks.
Yeah.
We found
The
that
block is it's gone in 12 hours.
it seems to be enough to get them over that initial post-op period, and they put these.
But I'm pretty sure it hurts more than 12 hours.
No, but then you move on to other multimodality. Unfortunately, we haven't gotten rid of all the narcotics.
No.
We
There's
give
no
typically,
replacement for an epidural if you got a thoracotomy. I think that's the best pain management you can provide.
If it works.
Yeah, if it works.
If you got a good anesthesiologist and they put a good epidural in, man, there's no comparison.
Yeah. We're still using epidurals, but we're trying to move away from it. We have a problem in some patients losing blood pressure, getting too much fluid.
Yes.
And this is
and interferes with ambulation. as well.
Yeah.
So this is the downside. Some people have started using paraspinal
Yes.
catheters, which are placed by the surgeon during minimally invasive procedure, and you can really accurately see that you place them correctly. And they claim that they work well. I know the group in Norwich, for example, Ed Chung's group is using that. And we're planning to go there to see it, bringing our anesthesia team too. So I think
this whole groundswell of enthusiasm for the liposomal bupivacaine, but I think some of the randomized studies now have not demonstrated much efficacy for the additional cost of that. Our institution would not buy it because of the cost.
Mm-hmm.
But you could just use the bupivacaine.
Yeah,
Yeah, that's fine.
it's good. So what about, we spoke in another one of these sessions about early feeding and the use of NG tubes. What's people's routines about feeding? Maybe Steve, start. When do you? I'm talking about oral intake.
Yeah, I always put a J-tube in, and that starts at day 3. I'm reluctant to do early feeding. I'm concerned about the risk of aspiration. So to me, aspiration trumps everything. I'm slow to feed, usually about 5-6 days. Nearing the end of the hospitalization, hopefully it falls well, and I'll start.
And you use an NG tube as well?
NG tube, if it's an open operation, NG tube until they have returned GI function. If it's laparoscopic, usually 48 or maybe 72 hours.
we use an NG tube for like 3-4 days usually. We always place a J tube. We start feeding actually first water at right after surgery, but from the first post-op day we give feeding formulas. They can start drinking actually water. This is in accordance with the enhanced recovery program, so they get 30 milliliters of water per hour from the first post-operative day, but we suck it up in the nasogastric tube, so I'm not sure that it collects or goes down so much. And as soon as we take out the nasogastric tube, which is when the output goes under 300 milliliters, which is day 3 or 4, then they start feeding clear fluids with calories. And then we have a stepwise, pretty slow increase because they're already feeding on the J tube.
Well, I stopped putting in a J tube a few years ago, largely based on the fact that our anastomotic leak rate was under 5% at that point, and I felt that I wasn't requiring it for most patients. And the tipping point was a laparoscopic or a minimally invasive esophagectomy patient who was ready to go home on day 5, which I would say is unusual for my practice. But there he was, ready to go home, but he wasn't up to his J-tube goal rate. And so he stayed in an extra 2 or 3 days just to get to his goal rate. And I thought, this is counterproductive. And I'm sure you've all had J-tube complications. I certainly have. I've had to reoperate on people. And so I just abandoned the J-tube. And then in terms of when to start feeding, I just start them on clear fluids at day 3, something like that, but maybe day 1.
Why not?
Yeah.
We have more or less the same system as in Stockholm. We limit the jejunal feeding up to a maximum of 1 liter until the patient has passed stool. And then we increase the volume up to what is required, but we limit it to 1 liter to prevent blowing of the abdomen. And apart from that, we do roughly the same as you.
There are some variations there.
Yeah. And we might change our practice now that the nutrient trial that you just mentioned has been finished. And the results will be published soon, I think.
Yeah.
So we might switch to liberal oral feeding.
So we know there are variations in the way the group here performs their anastomoses. What sort of variations are there in testing for anastomotic leak? Does anybody do routine testing for anastomotic leak before, for example, taking the NG tube out or allowing oral intake?
No, we don't do it.
I still do upper GIs before oral intake, mostly to confirm for myself anastomotic integrity. There are patients that have a subclinical leak. And I think if you feed those patients, you can turn subclinical into clinical. Not great evidence for that, but also give you some comfort and then make sure the graft is emptying properly and then going to deal with aspiration.
I don't routinely study them anymore now.
We did it in the past, but we stopped doing it. But we are very liberal in making a CT with oral contrast if there is any clinical suspicion of leakage. So we have a very low level to do it, but we don't do it routinely.
Yes, we moved to the CT with oral contrast if we have any concerns, because it may not be as sensitive as a barium, but I think it's more than adequate for determining something that requires intervention. And it also tells you if you've got drainable collections that you need to deal with.
Yeah, we have a low threshold too for CT with oral contrast, water-soluble contrast, but also for endoscopy. So if we're in doubt, we take the patient to the endoscopy suite, or actually in full anesthesia in these early phase patients.
I know there's some concern been expressed about the risk of aspiration. That's not just a regurgitation type of aspiration. They can aspirate when swallowing, right? So for those of you who are doing cervical anastomoses routinely, do you do any sort of evaluation for swallowing efficacy prior to instituting oral intake?
In the past, we almost always had a cervical anastomosis for historical reasons. Now our preferred place is the chest. But even if we do a cervical anastomosis, we don't test the swallowing. We let them swallow first water and then solids, semi-solid.
Did you give them any advice about swallowing when they?
Yeah, well, the most important advice I think is sit in a chair and not in your bed when you start swallowing. That's, I think.
I always tell them to do a chin tuck when they're with a cervical anastomosis.
That's another advantage of the upper GI. If you see the aspiration in the upper GI, frequently it's sort of induced because they're told to hold their chin up and so forth. But I will tell those patients, tuck your chin down as you swallow.
Yeah, we don't do any testing either. We do maybe 20% cervical anastomosis, and in these patients, we let them test a little bit. It's a good point that they should sit in a chair and tuck the chin up.
I'll tell you, my partner will not let anybody, not just esophagectomy patients, but anybody in the hospital take anything by mouth unless they're sitting in a chair, not even on the edge of the bed. So that may be going a little further than I would. So tell me about J-tubes. Almost everybody is putting in jejunostomy feeding tubes. What's the incidence of complications?
Well, I mean, the most common complication is that there's some leakage along the tube of bile and the small bowel fluids. It's a very small problem. We have seen very few major complications after esophagectomy, while we saw a lot of serious complications after total gastrectomies. So we actually stopped doing it together with the Roux-en-Y reconstructions, and I don't really know why, but we had several situations with rotations. But after esophagectomy with a gastric tube reconstruction, we see very few serious complications. We've had a couple of infections in the abdominal wall and requiring, incision, so on, but very rarely anything more than that.
With your Roux-en-Ys, where were you putting the J-tube?
Well, maybe...
In the alimentary limb?
No.
See, I think if you have a Roux-en-Y, put it in the alimentary limb and put it over on the right side. It tethers the alimentary limb nicely, so it doesn't get all coiled and redundant, and it's very safe there, and you just feed the tube down beyond your jejunostomy.
That's a good idea.
But I have very few complications. I always put an anti-torsion stitch in.
Yeah, so do we.
Distally to prevent
It sounds very automotive.
Maybe.
Works okay.
It's okay. Just prevent that.
I'm going to change direction here for a minute and talk about regionalization of care. Now, in some countries represented here, I think that's already established. But what about places like the U.S.? What's the demonstration of the advantage?
Well, I think the advantage is pretty clear. Places, Canada's adopted, and I think there's clear benefits to that. The downside is that it's difficult to get many patients, particularly in America, to accept. They want to have treatment close to home frequently. I think it's going to require a mandate by insurance that you don't get your operation covered unless you go to a center.
So in the U.S., the issue is if you, let's say, establish a region must do 100 or even 50. The average additional distance that the typical patient has to travel is 300 miles to reach one of those centers.
I think it probably depends on how you ask these patients. We've had attitude investigations with patient organizations and patients in Sweden, and patients are extremely clear. They can travel any distance to get a better operation. That doesn't matter at all. The operation is one day of surgery and 1 week in the hospital, and that doesn't matter. It's a completely different thing, I think, for patients with like radiotherapy or something which needs repeated visits. But Swedish patients
have a much more intelligent patient population than we do.
I think it's about how you present the information and who presents it. If you want to, make the patients say that they want treatment close to home, you can of course make them say that. But if you present that all international data actually show that the chance of surviving surgery, of getting cured of the cancer, is higher if you go to a high volume center, I think most patients would say, okay, I think it's worth it. But if you just say it's the same care, do you want to do it far, far away, or do you want to do it in your local town? Of course they would say the local town, but it's about presenting the information.
So how long has Canada had regionalization?
In Ontario, we've had it since 2008. British Columbia since probably before that. I think Quebec just recently adopted it.
So have there been demonstrable advantages?
I think that it's not been well studied, but certainly the mortality, both 30 and 90-day mortality is lower, length of stay is lower. We haven't looked specifically at complications like leaks and that sort of thing, but certainly mortality is definitely lower.
I think one of the effects you see, we have a national population-based, database, is that we don't see less complications, but because what we see is that we treat more patients with a curative intent. With centralizations, we dare to treat a little bit more frail patients that would never have curative therapy in the local hospital. So we can't really show a lower leak rate, but when we look at a population level, we can see that the percentage of patients getting curatively intended treatment is much higher in the larger centers compared to the smaller centers. So it's very complex. Just looking at
it's not just about complications.
No. It's a more complicated equation.
The other issue is with regards to the complications. The centers of excellence have more resiliency in their patients because of the algorithms for detection and management of problems. And if you even put those abilities into a small hospital, they'll have very similar results, recovery from complications. So it's not just about volume.
No.
Its ability to rescue.
Yeah.
Rescue, right?
Rescue.
Yeah, so the way you treat complications, you handle them,
Yeah.
is perhaps more effective in the high volume. So the incidence of the complication might be comparable, but the way you handle it, you manage it, might be more professional, might be more effective.
But probably if you treat the same patients, you would have lower complications. But with the ability, with the confidence you get from high volumes, you start treating patients that were borderline before. And we saw a drop in complications when we implemented minimal invasive and enhanced recovery. So we have the same complication rate now because we started to operate a little bit sicker patients that would have had palliative treatment before.
As an interesting point, I had a patient recently who I wanted to send for trimodality, and the medical oncologist and radiation oncologist sent him to the geriatric oncologist for a frailty assessment, and the geriatric oncologist said he was too frail, but I should operate on him. And actually, he did very well from his operation. He, just kind of sailed through smoothly, and they were all astonished that we got this guy through. And I didn't think he was frail, but he was too frail for
You
that.
clearly didn't have very good surgical judgment like you did.
But coming back to the question why the US or why some countries do centralization or regionalization and some others do not. When this issue came first up in the Netherlands, it took 7-8 years before the surgical community was willing to accept the concept. In fact, I did an analysis for the first time on the relation between volume and mortality, and nobody picked it up. Until 7 years later, the lay paper published a small publication in the newspaper, and then it all started. So it is my impression, the problem might not be the patient who doesn't want to travel, it might be the surgeon who doesn't want to give up esophageal surgery.
I think that's absolutely right. This is the problem. It's not the patients, it's the surgeons. Nobody wants to give away something that they're doing and that they feel that they do well and so on. I mean, it's human.
Yeah, that's exactly. And when I first published this in the Dutch medical journal, people got angry on me.
Of course.
I said, this is not my numbers, this is your numbers. And they could read that this was a problem, this was unfriendly.
I think
and the bottom line was that the patients finally
pushed it through.
The system.
Yeah.
Well,
It took 7 years.
An important concept. I think we'll have to end the discussion there. Thank you all for your participation. I think it was very interesting.
Thank you.
Thank you.
Pleasure.